Hi, I'm Dr. Robert Kaufmann, and we're about to go beyond the terminus. Today we're going to discuss treatment planning of a patient who arrived in my office complaining of soreness in the gingival area in between a couple of teeth. The referring dentist had referred this 71-year-old male patient in good health for treatment of irreversible pulpitis associated with the first mandibular molar, number 36. The patient's current complaint was an occasional soreness in the gingival area adjacent to the mandibular left first molar, number 36, and the second premolar area, number 35. He mentioned that when he was using a water pick, he would occasionally get material flushed out of this area. The discomfort was described as minimal, but the referring dentist suspected that there was a radiolucent finding at one of the apices associated with number 36. Both number 36 and the mandibular second molar, number 37, had been crowned with gold onlays, and they were in good condition. The first thing that we did was to take some new images because the initial periapical image provided to me by the referral was not diagnostic and didn't show the roots clearly. Periapical radiography revealed no unusual findings associated with any of the teeth. CBCT imaging also showed no unusual periapical radiolucent findings associated with either number sign 35 or number 36. Bite wing radiography showed that the maxillary first molar, number 26, had been previously extracted and that number 36 was unopposed. More importantly, there appeared to be a fracture of the DO composite restoration in number 35 as visible in the bite wing. Clinical examination revealed the presence of a fracture on the distal marginal ridge of the composite in number 35. Percussion, palpation, and chewing sensitivities was within normal limits for all teeth in the quadrant. PULP tests performed on all teeth produced a positive response in 37, an ambiguous response in both 36 and 35, and a positive response in 34. Therefore, the thermal tests were not really helpful in us being able to determine whether there was a vital pulp associated with the patient's current complaint. Probing of the fractured area with a perioprobe in the area of the open contact between number sign 35 and number 36, where the fractured composite was, elicited the patient's discomfort exactly. The interproximal papilla area bled fairly easily when probed. Examination of the occlusion revealed that number 36 was unopposed, and that most of the function on this side was being generated between the maxillary second premolar, number 25, and the distal marginal ridge of number 35, the second premolar in the mandible where the composite had fractured. I explained to the patient that the large DO composite in number 35 was unable to cope with the continual pressure and function, and that this material would not hold up under the current occlusal scheme. I recommended replacement of the maxillary first molar, number 26, with either an implant or a bridge. The patient mentioned to me that he was in the process of having the implant placed fairly soon. The diagnosis of acute periodontitis secondary to the open contact between number 35 and number 36 was made. I suggested to the patient that they return to their dentist and discuss options for re-restoration of number 35 with the fractured composite. The existing composite restoration was quite deep, and it was possible that they could either, number one, consider replacing the composite one more time, and once the unopposed number 36 was opposed by an implant, this may lessen the stress on the distal marginal ridge of number 35 and relieve us of the need to have number 35 crowned. Alternatively, number two, the referring dentist may feel that the composite's too large to be prepared for a crown without elective endodontic treatment of 35, and that treatment of this tooth with a root canal may be necessary before the tooth can be properly crowned. The patient was referred back to the referring dentist for discussions regarding treatment of this side of the mouth and consideration of how best to restore this side. Part of the job of the endodontist is not only just to do endodontics, but to examine the different areas and different problems that patients may have. Their expertise lies in diagnosing situations which frequently may be endodontically related, or they may not be. They may require endodontic treatment, but they also may not necessarily need it. That's why it's so important for referring dentists and specialists to work together to ensure that the correct diagnosis has been made, the correct information has been transferred between clinicians, treatment alternatives have been discussed, and that proper informed consent is obtained prior to initiation of any treatment being contemplated in the patient's mouth. Remember, when we do the right thing, we both get better, patients and clinicians. Thank you for joining me on this edition of Beyond the Terminus. Don't forget to like and subscribe. I hope to see you again when we go Beyond the Terminus.